Hey everyone, this is Chris. I am recording this on Monday, the 13th of October. And I have a cat hair stuck in my mouth, sorry. Okay, there we go. So we are going to be talking today about the DSM. Um, I will be completely transparent that this is something that I am just learning myself. Um, I did the overview, back when I was in the program, but this is kind of new to me as well. So this, I'm going to be referring to some notes, and if you have questions, I'll need to dig a little deeper. Um, cool. So, one second here. All right, let me get back into my PowerPoint presentation. Cool. So yeah, this is week 9. And I did get some lecture material from Professor Mary Foster and Dr. Perry. So wanted to give them credit where credit's due. For the check-in this week, I wanted y'all to take a listen to this music video. There's no lyrics or anything like that, but it's been scientifically tested and proven to help reduce anxiety. So the link itself is in the PowerPoint here, and then this is the article, one of the articles that talks about the testing that was done, about how, yeah, how it can help. I used to listen to this song kind of on repeat when I was working on schoolwork or when I was feeling particularly anxious about something. So this might be something useful. It's about 8 minutes long. And yeah, it's just kind of like a nice kind of rhythmic pulsing kind of sound. It's a little electronic-y, but not like high-pitched or high-paced or anything. Okay. Alrighty. So, just our weekly check-in here. General reminders, you've got your weekly assignments and activities. So this week is week 9. And you have no coursework during week 10. So next week, so a week from today, so that would be the 20th, which is when your quizzes are due, which I think almost everybody's already done. And then, let's see here. Yeah, you don't have any assignments or readings that week, just so that you have the ability to work on the skills demonstration recorded session. Just a general reminder again, it's 10 to 12 minutes long. It's like the recording itself, the self-assessment and the skills checklist. So you basically go in and do like a self-evaluation on that with a transcript of your words, like what you had written, uh, as well as the consent form. So those 3 pieces, 2 to 3 pieces, depending on if you need the consent form, those are what you're turning in, and that's due by November 10th. So you do have some time to do that. I know there's some questions about the peer groups. So if you have any particular concerns or questions, let me know. But I specifically set up this week's small group discussion and scavenger activity to be done with your assigned peer groups. So yeah, this is a good time to just check in with them and get an idea of everybody's schedule. So there's only one optional synchronous Zoom meeting left. That'll be to discuss the final paper and the other options for it. And that is going to be on Monday, November 10th at 9 a.m. your time, 11 a.m. my time. And just a general reminder again that there is an optional makeup assignment if you miss a week. Although I'm being pretty lax as far as if you're going in and getting some work done a little bit late, because I know this is a pretty stressful time of the semester. Oh, you're also getting an email, or should have received an email from Becky Cottrell today to complete and participate in a 2-part midterm feedback session. So it's not just for me, but it's also for the school itself, based on the fact that we've revamped a lot of this material. So any feedback you have, again, there's 2 parts to it. So you've got a couple of days to go in and introduce some initial thoughts. And then you have another, it's like going to be towards the end of this week, an opportunity to go in and have some specific points there. Okay. So please don't don't avoid your email. Check that and participate. Cool. There we go. So week 9, we're going to be talking about the DSM-V-TR and ethical diagnosis. So we're going to talk a bit about the history of the DSM, the timeline of the DSM, take a look at the actual DSM, and then talk about trauma, oppression, and stigma in relation to the DSM, tips for ethical diagnosis, or as close as we can get to it, and just practice integration with based on the readings that we've done so far. So the history of the DSM prior to like the early 1900s, there were asylums, and each asylum would have its own diagnostic system and treatment system. The treatment team would vote. Starting in 1918, they had the Statistical Manual for the Use of Institutions for the Insane. And then post-World War II is when we really start to see the DSM like kind of emerge. So if we look at the timeline, so 1952 is when we have the first version of the DSM. It was only called the Diagnostic and Statistical Manual of Mental Disorders. It did not carry like a number attached to it because it was the first one, and it had 60 disorders originally. The first edition and then the second edition, which came out in 1968, so the DSM-2, were based in psychoanalytic traditions. And like I said, too, that first DSM was created after World War II. It was partially a reaction to the return of military veterans from the war, because many veterans showed non-psychotic but non-physical disorders. And a number of the military medical officers from World War II turned their attention to the treatment of these types of disorders. So let's take a look here. And this is where I'm consulting my notes. The third version in 1980 here, the DSM-3, favored a biomedical model. And then the DSM-3R, so that was where there was some revisions. It changed the diagnostic criteria for several mental illnesses. And then the DSM-4 came out in 1993, 1994-ish. It had an interim text revision called the DSM-V-TR, which, yeah, that was in 2000. And it's now taken shape as the DSM-5. Well, the DSM-5 came out in 2013, and then now we're at the DSM-V-TR, so that's the text revision that came out in 2022. Let's see here. The DSM, like the original DSM, contained a glossary of descriptions of the diagnostic criteria categories, and was the first official manual of mental disorders to use on or to focus on clinical use. Yeah, it used to have like a hierarchical system, and that was that psychoanalytic and then biomedical model. Like that's kind of how it's evolved over the years. So we're going to take a look at kind of just the anatomy of a diagnosis, and then the like what the difference is between like an ICD-10 versus a CPT code. This is like when you're talking insurance and billing, and both are present in the DSM, so it can get a little confusing because there's two sets of numbers and letters with it. So if we go into, which y'all will be doing, like for example, if you pick one diagnosis, for example, it's got the structure of it has the name of the diagnosis, the diagnostic criteria, and the ICD-10 code, the diagnostic features, associated features, prevalence, development and course, risk and prognostic factors, culture-related diagnostic issues, sex and gender-related diagnostic issues, differential diagnosis, and comorbidity. I know that sounds like alphabet soup, and just like a whole lot of stuff. But if we actually go into the DSM, you'll see like, so for example, if I go in to why don't I go into like bipolar? Oh, and it's making me log in again. There we go. Okay, so for example, this is basically, the name here, bipolar 1 disorder. So we've got the diagnostic criteria. It has to meet the following criteria for a manic episode. And it also, may have been preceded by or followed by a hypomanic or major depressive episode. So it gives you the criteria and a note. And then specifically that criteria A through D constitute a manic episode. At least one lifetime manic episode is required for the diagnosis of bipolar 1. So it kind of goes through here, and then A through F constitute a hypomanic episode. So these are pretty common in bipolar 1, but they're not required for the diagnosis of bipolar 1. A manic episode is. So essentially it's a major depressive episode, and it's, got to follow at least the diagnostic criteria here. Yeah. So coding and recording procedures, they do have like mild, moderate, severe with psychotic features, impartial remission, in full remission, and unspecified. So these are your like ICD-10 codes here. Okay. Um, and it gives you some specifics. I'm only going on this high level here. You can specify with different, I don't know, I call them flavors because, like, for example, I've got somebody with bipolar 1 who is starting to go into a depressive episode, and there is, a seasonal pattern. So I could, kind of specify with this. The diagnostic features is really nice because it gives you a breakdown of what to expect, like how symptoms present. It's really helpful to, like, when you're if you do have to diagnose folks, really reading through that, associated features, the prevalence. So again, giving you an idea of if the person in front of you statistically could be within that. Like if you're starting at a new practice and you've got like 10 folks with bipolar who come in like right in a row, right? That's statistically not very plausible. I don't know if I'm saying that right, but this talks about the development and in the course. So how it will present, usually bipolar, uh, let's see here. The peak age at onset of bipolar 1 is usually between 20 and 30 years of age. But it can occur throughout the life cycle. So, just giving you an idea of the age range of folks that you would be looking at, the possibility of if you have a single manic episode, like if you're going to go into further episodes in the future potentially. So the risk and prognostic factors. So we're talking environmental, we're talking genetic and physiological, culture-related diagnostic issues. So if culturally there's something that is accepted or shunned or what have you socially, this gives you like cultural factors that may affect the disorder like prevalence in a population. It also talks about sex and gender related diagnostic issues based on, the studies that they've done, association with suicidal thoughts or behavior, functional consequences. And then this section is, I think, the most helpful. It's the differential diagnosis section. So if you have somebody who's presenting with some symptoms of bipolar 1, but you don't know, it doesn't quite fit the full diagnostic criteria that we met up top, or that was at the front of the chapter or the diagnosis, this is like, these are the other things that it could be. So like it could be just major depressive disorder. It could be other bipolar disorders. So bipolar 2 is another, possibility. It could be generalized anxiety disorder or a panic disorder or other anxiety disorder. It could be bipolar disorder because of a relation to another medical condition. Um, and, sometimes if an individual's utilizing substances or medications, those can induce bipolar or related disorders. Um, but yeah, schizoaffective disorder, it could be presenting as bipolar, but then you've got all these different options if it doesn't quite fit the criteria. It also talks about comorbidity. So you want to do, how like in math, when they give you a big long equation and the point of the equation is to kind of like, get it down to what its essence is. Really, when you're using diagnostic criteria, you want to have the least most diagnosis that encapsulates the most of the symptoms, if that makes sense. So like if somebody is having depression and mania, like you could put them as MDD, like major depressive disorder with anxiety, or generalized anxiety disorder with, all these other things. But it's like, okay, but if we fit that under bipolar 1, that encapsulates all of the symptoms with the least number of diagnoses, if that makes sense. Um, so yeah, I love this little section here. It's just super helpful when you're just getting familiar with that kind of thing. So hopefully that was kind of helpful um, to do a little walkthrough there. Let me view. Let's go back to the slideshow. So that was of course, it started all over. Bear with me. You can tell I'm having a bit of a day, but that's okay. So yeah, that I took you just through all of the anatomy of that diagnosis, right? So the ICD-10 versus the CPT codes. So we saw, like, for example, when I showed the bipolar 1, major depressive disorder is F32.1. We saw that F code, Um, the ICD-10 code is diagnostic. Usually in notes, a DX, indicates diagnosis, and then TX indicates treatment. Um, so the ICD-10 is a diagnostic code. Like this is the reason somebody is receiving care. And the CPT code is usually, it looks kind of like a zip code. This is like the billing code. So, the billing code is what we would like uh, ascribe as like what we're trying to, or what we're doing to address the issue or issues at hand. Okay. Um, it's a treatment code. Like, so we're doing 60-minute individual psychotherapy sessions. Like that's primarily what I do in my practice now. There's things like family sessions. You can do 30-minute, 45-minute, and 60-minute, I think. Those are the ones you can generally bill for. Um, and then there's some other things that you can bill for depending on the insurance companies, and what their preferences are. So if you're going into private practice, you really need to know this. If you're going into group practice, usually there's somebody there to train you or to help you with the billing stuff. Um, but those are the two main differences that you'll see. And you'll notice too in the CPT, there's not usually a letter. Okay. So as far as, the DSM and trauma, oppression, and stigma, I mean, if we're looking at the history of, mental health and also, who's been tested for what, who has had access to care, I mean, we can look at, there have been so many like horrific experiments across history that have been inflicted upon um, people of different populations, like the Tuskegee experiments. The just there's just so many examples. It's hard to pick one. Um, Racism and ethnoviolence, like, very much are prevalent in the DSM, as far as like how the research kind of shaped it. Um, I think they're trying to get to the point of doing better, but I think, there's this thing right now about how like autism is everywhere. Like, oh, we've got autism everywhere. Um, and some people are saying that's because of social media and all this other stuff. But a lot of what we were looking at, like what people were testing back in the day, were cisgender heterosexual white men. And so when we look at ADHD and we look at autism symptoms, it presents very differently in men than it does in women, or people who were assigned male at birth versus uh, folks who were assigned female at birth. And a good portion of that could potentially be attributed to societal gender roles and how we are, programmed to be and what our behaviors are considered acceptable and not, socially. So there's also like complex and developmental trauma. Um, I mean, I know we're trying to shift criteria, right? It's just never, it doesn't feel like it's ever going to be enough because there's not really a way that you can use a net like the DSM to weave together something that's going to capture everybody, as far as like folks who are experiencing symptoms. I would also say too that that one quote, I think it was in my first lecture that I did, it might have been the second one, where it's like, it's no measure of health to be sane in an insane world. I think a lot of people are experiencing symptoms of anxiety and depression that might not necessarily be because they are, um, having unreasonable reactions to the world and their environment around them. It's not paranoia if you actually are, being persecuted. So just, keeping that in mind. We've got like complex and developmental trauma, like CPTSD is not a diagnosis yet, although a lot of people that I've talked to, people in the field who are familiar with these things, like their CPTSD is like if you have like a cumulative trauma essentially over the lifespan, like PTSD, it feels like there's just kind of one big event and then the ramifications of that. But if you have multiple events over a lifetime, or in a short period of time, it can be very difficult to parse that out, and to treat it because it is different, than one event, Um, I mean, there are limitations of the DSM-5-TR PTSD criteria, psychosis, and there's racial and gender discrimination in the diagnostic criteria. Like it just it exists. It's I mean, there's like in the medical industry, we've got in healthcare, like for example, the what is it called? The BMI, the body mass index. It's been proven like with data that it is not an actual measurement of anything, but yet we still cling to it in the healthcare field, like because it is a measure and it is a way that insurance companies can deny people care. It's pretty awful. Um, so just, it it's the manual that we have. It's imperfect. Um, there might be ramifications when we diagnose somebody with something. And so, for example, bipolar is still very, 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 misunderstood and misjudged. There's a lot of shame and societal rejection. Like, there's potential for not being able to get a job. Same with like, uh, so many of the diagnoses. Um, so yeah, just wanting to hold the space for that. Um, so some tips for utilizing the DSM in your practice if you are having to diagnose anybody. Um, Try to diagnose for the least invasive diagnosis that is like still the most accurate, right? So um, try to go for like the simplest explanation. Don't dive too deep, if you don't have to. Um, Use a diagnosis from their past that is still active and accurate. I can tell you right now, a lot of people that are coming into my office already have existing diagnoses. Some are already receiving medication. for existing diagnoses. So I asked them, I'm like, hey, what are your current diagnoses? Okay, how do you feel about these diagnoses? Like, do these feel accurate based on what you know and understand of these, mental health conditions, Um, adjustment disorder can be a helpful placeholder, but I do want to put a caveat on that. Adjustment disorder is usually like a 6 month or less situation where you've been through a divorce or you got laid off or you had a loss in the family. Adjustment disorder can be a placeholder, but again, only for that 6 month window. You do need to flag that to come back and reassess and come up with a different diagnosis if the client is needing further treatment, because insurance companies will claw that money right back. um, and you also can't just give everybody adjustment disorder. That is also statistically improbable. Um, check your biases, and check for over pathologizing. I think it's very tempting to lean into these resources and to get too invested or curious about like the different symptoms and how they present. Like this is a this is the placeholder, this isn't the work itself, right? The work should be in the room with your clients. The work shouldn't necessarily be the diagnosis itself, right? um, and yeah, collaborate with the client, collaborate with your supervisor, your peers, your colleagues. um, there are several different ways and approaches to diagnosis. The main thing at the end of the day, like, how you write your notes and everything, it's imagine you have your client kind of over your shoulder reading the notes that you're writing, and just um, with that diagnostic piece, you want to make sure that you're including the diagnostic criteria that the client meets. But again, you're wanting to write it as if the client is reading it too, not just the insurance companies or your supervisor, you know? So if we're just integrating this all to the just practice integration, um, as far as meaning goes, what story does the client tell about their experience? What are they saying? What is their narrative? And how have they made meaning out of it? Out of what they've experienced? Have they made meaning out of it? Is that what they're here for? Context, what environmental factors might shape their symptoms? So, this is our world today, right? But also, what's their home life like? Are there any other stressors or, strengths that are happening that might shape their symptoms or how they're dealing with them right now, power. How can you share diagnostic decisions collaboratively? Being able to slap a label on somebody like a DSM code is a powerful thing, and it can negatively impact the client in front of you, for real. Like that diagnosis or misdiagnosis can haunt that person and follow them places that they would not anticipate. I had a client come in who did not know that they were diagnosed bipolar 1. It just came over as like, as part of the referral process. That person, like whoever diagnosed that person, did not collaborate with the client on that, and that made the client feel really crappy. It's almost like you've been hiding this from me, kind of. And that makes folks not want to engage with the medical practice or mental health practice. Like, yeah. Um, history, like how has this diagnosis changed over time? I didn't want to get too specifically into this, but like being gay, being queer, over history, that I mean, that was, I think, gosh, I think only in 1994, I want to say, did being homosexual like no longer meet like a diagnostic criteria. Um, if you're transgender, that is a whole other story, and it can be very othering that you have to be diagnosed with something called gender dysphoria, um, or something similar to, get the treatment you need to be in the body that is, affirms who you are on the inside. Um, Yeah. How have these diagnoses changed over time, and how might that be impacting the client and that environment, that contextual environment that we're talking about also includes history, the history, and how the history is now present, or informs the present. Possibility, what pathways toward healing emerge beyond the label? So, especially if we're talking, something that can have a negative connotation to it, like addiction, like gambling addiction, even, for example, or bipolar one, like if we can kind of flip the diagnosis on its head, and try to get a little bit deeper into it, like, okay, usually a label like this, like a diagnosis like this, allows us to look beyond that and to what are the typical treatment practices? Like, what are the best practices for the people who work with this and just this thing, There are people who specialize in addiction. There are people who specialize in, mental health, like anxiety or depression, or like the different areas, within the DSM. So like, what are those people like saying? What are the experts saying about the best ways to deal with these things, the best treatment plans, the best steps, the best ways to help the client retain their humanity and their identity, while also being able to work towards whatever goals you establish in therapy. Um, being able to do their day to day a little bit easier. My closing thoughts are just that I'm a little bit out of it today, so thanks for your patience. Um, yeah, I hope y'all are doing okay. Again, you've got next week off from this class at least, so I'm going to try to jump in and do some more lectures as well as some ethics corners. But yeah, all right. You know where to find me if you need anything. Thanks so much.